Welcome back to the Deep Dive. Today we are jumping into, well, one of medicine's most ethically charged specialties, obstetrics and gynecology.
It really is. I mean, this is a field that covers the entire human experience. You're dealing with conception, huge reproductive decisions, and all the way to end-of-life care.
So for anyone listening, medical students, young professionals, getting a handle on this ethical framework isn't just helpful, it's non-negotiable.
Absolutely. Our goal here is really to give you that blueprint, a structured way to make reasoned, reliable judgments.
And I think we need to be clear from the start about what we're aiming for. This isn't a quest for certainty, is it?
Not at all. That's a huge misconception. If you're looking for a rule book with a guaranteed right answer for every single case, you're going to be disappointed.
So what is it then?
It's the quest for reliability. We're looking for evidence-based, rigorous ways of thinking that help us improve our practice, knowing that things are often ambiguous.
Okay, so to get started on that quest, we need to define our terms. When we say ethics, what are we actually talking about? How is that different from just, personal morality?
That distinction is everything. So morality is what we actually believe, our personal feelings about what's right and wrong.
Okay.
Ethics, on the other hand, is the disciplined study of that morality. It's the intellectual process we use to analyze and hopefully improve it.
So ethics is the tool, and a morality is the thing we're working on.
Exactly. And that tool has to be grounded in facts, in reality. Ethical judgments have to avoid two big dangers. First is enthusiasm, that's basing your beliefs on a lack of evidence.
On the second.
Speculation, inventing these wild hypothetical situations that don't really happen at the bedside. We need concepts that actually work in the clinic.
Let's lay that foundation then with the 4 prima facie ethical principles. Now, you said that term, prima facie, is probably one of the most important things to understand here. Why is that?
It really is. It speaks to how we handle conflict in medicine. Prima facie means on the face of it, or unless otherwise proven.
So there are obligations, but they can be overridden.
Yes. If you have a strong, reasoned ethical justification, they are absolute rules, which is so important because, absolute rules just don't work with the complexities of the human body.
There's strong defaults. Okay, let's walk through the 4.
We always start with beneficence. This is the positive duty, the obligation to act for the benefit of your patient, to provide care that's predicted to result in a net clinical benefit.
And right alongside it, you have its counterpart, non-maleficence.
Right. The duty to prevent or avoid causing a net balance of harm over good. And critically, this also means avoiding the harm that comes from overtreatment.
That's a key point, doing too much when the evidence isn't there.
Exactly. Then you have respect for autonomy, which is, constantly in the spotlight in Obgyn.
I'd imagine so.
It's the obligation to empower patients, to help them make informed, voluntary decisions, and to respect their right to make choices based on their own values, even if we as physicians disagree.
And the 4th one, healthcare justice, seems to zoom out from the individual patient.
It does. It expands our scope to population health. It's the obligation to ensure that all patients, female, pregnant, fetal, neonatal, have access to medically reasonable care and to address those, disparities in care.
This all seems to build toward this idea of professional integrity. And you trace this back to the 18th century, to Gregory and Percival. Why are they still so relevant today?
Because they basically invented the modern job description for a doctor. Before them, a physician was often just an entrepreneur, a man of interest, and the public, frankly, didn't trust them.
So professionalism was a solution to a crisis of trust.
It was a social contract. Their work transformed the doctor from a self-interested businessman into a professional who is committed to 3 core things. First, scientific and clinical competence. That's intellectual integrity. Second, putting the patient's health above your own individual self-interest. That's moral integrity. And third, putting patient interests above your group's self-interest, like your guild or profession.
And to maintain that kind of integrity over a long career, you need certain habits or virtues.
Yes. And beyond just integrity itself, there are 2 that are maybe the most challenging: self-effacement and self-sacrifice.
Self-effacement. That sounds a little strange. What does that actually look like in the clinic?
It's the habit of identifying and then actively ignoring any feature of a patient that is clinically irrelevant but could bias your judgment.
Like their wealth or their social status.
Exactly. Their financial status, their race, whether you think they're worthy. Self-effacement means the VIP and the most disadvantaged person in your community get the exact same level of careful, deliberative management.
It's an active fight against bias. That makes sense.
Yeah.
What about self-sacrifice? That one sounds a bit risky, especially with all the talk about burnout.
And that's why it has to be defined very carefully. It's the habit of taking reasonable risks of harm to your own legitimate self-interest.
Your income, your reputation.
Your sleep, all for the sake of the patient's care. It does not mean being reckless, but it does mean putting the patient first when there's a real conflict and the risk to you is reasonable.
Okay, that history really frames the practical side of things. Which brings us to patient decision-making. Before we even get to consent, we have to talk about capacity.
Right. And capacity is the clinical concept. We use it pretty interchangeably with the legal term competence in the clinic. The most important thing to remember is that capacity is always presumed.
So the burden of proof is on the clinician to say it's not there.
Always. And to check for it, the patient really has to demonstrate three things. First, a cognitive understanding of the information, the diagnosis, the options. Second, an evaluative understanding.
Meaning they can weigh the options against their own values.
Precisely. And third, they have to give explicit authorization and be able to communicate the reasons for their choice. If they can't explain why, the decision is rigorous.
And that rigor is reflected in the different types of consent. We need to distinguish simple consent from the full, informed consent process.
Right. Simple consent is fine for low-risk, non-invasive stuff, like a routine blood draw or telling a patient to take folic acid. A simple okay is enough.
But in obgyn, the stakes are usually much higher. Major surgery, a complex delivery plan, that's where informed consent comes in.
And that has to satisfy two big standards. The reasonable person standard, what any patient would need to know to make a decision, and the professional community standard.
What does that second one mean?
It means you have to disclose the evidence-based details about quality and safety. For example, if you're talking about a trial of labor after a C-section, you have to talk about the specific risks according to the best available evidence.
Now, what if a patient has full capacity, understands everything, and still refuses what you think is the best course of action?
That's informed refusal. And it's a very strict obligation. You must respect their refusal. That's their autonomy. But your duty of non-maleficence means you also must inform them of the specific clinical risks they're taking by saying no.
You have to make sure they know what they are choosing against.
Yes. There was a landmark case, Schumann v. Thomas, where a physician was held liable for not telling a patient the risks of refusing a pap smear. That same principle applies today.
What about when capacity really is impaired? What's the approach then?
It's a continuum. You always start with assisted decision-making. Try to reverse what's causing the impairment. Maybe wait for an acute illness to pass.
And if that doesn't work?
If capacity is diminished but not gone, think of some minors or geriatric patients, we move to ascend. The more adult-like their capacity is, the more weight you have to give their opinion, even if they can't give full consent.
And the last resort, when capacity is completely lost.
Then you need surrogate decision-making. And the surrogate has a clear hierarchy to follow. First is the substituted judgment standard.
They have to decide what the patient would have wanted.
Yes, based on their known values. Only if that's impossible do they fall back to the best interest standard.
Okay, last thing in this section, confidentiality. This used to be an absolute rule, but now it's prima facie, just like the principles. What changed?
Well, we realized its justification is twofold. It's autonomy-based, of course, respecting privacy, but it's also beneficence-based.
How so?
It encourages patients to be honest, especially about sensitive things like substance use or abuse, because they trust you won't immediately report them. It builds that therapeutic relationship.
So when is it okay to break that trust? When does non-maleficence win?
Only when there's a clear, serious threat of harm to others. The classic examples are mandatory reporting of certain STDs or the legal duty to warn a third party, like in the Tarasov case. It's rare, and even then you have to tell the patient why you're breaching confidentiality.
Now, the moment we bring a fetus into the equation, the whole ethical dynamic it explodes.
Yeah.
How do we even begin to think about the fetus as a patient without getting stuck in philosophical debates about personhood?
We sidestep that gridlock by using the concept of dependent moral status. This means the fetus's status as a patient isn't independent. It's created by the professional relationship the pregnant woman starts with her physician.
It's a clinical reality, not a philosophical one.
Exactly. And the other implacable reality is that you can only access the fetus through the pregnant patient's body.
Which means you're suddenly balancing three things at once.
Three prima facie obligations, yes. Maternal beneficence, maternal autonomy, and fetal beneficence.
And does one of those automatically win?
No, absolutely not. It's always a balancing act. An intervention for fetal benefit is only medically reasonable if there's strong evidence it will help, and it doesn't pose a greater than reasonable risk to the pregnant patient now or in the future.
So the pregnant patient isn't obligated to take on huge risks for the fetus.
She is not. Now, when we talk about analyzing the fetus, language becomes really important. You recommend avoiding terms like screening or testing.
Yes, we advocate for using fetal analysis
hmm
and then specifying if it's a non-invasive or invasive method. It's just more precise. We also have to talk about moral risk.
Moral risk?
Yeah.
What is that exactly? It's the risk a patient takes by getting information that might present them with a choice they find morally unacceptable, like terminating a pregnancy.
So if a patient refuses fetal analysis because of that moral risk, maybe due to their religious beliefs,
Yeah.
what's the physician's role?
To fully and completely respect that refusal, trying to coerce them into it would be a profound violation of their autonomy and of your own professional integrity.
Let's talk about counseling styles. We know we often need shared decision-making, but are there times when a doctor has a duty to be more direct?
Yes, absolutely. That's what we call directive counseling. It's ethically required when there is only one medically reasonable option or when one option is clearly demonstrably superior based on evidence.
Can you give us a clear example of that?
A good one is planned home birth. Now, the evidence is quite clear that compared to a planned hospital birth, there's a significantly increased risk of neonatal mortality and morbidity.
Even if the absolute numbers are still small.
Right. The comparative risk is significant enough that a physician has an ethical duty to strongly recommend against it to honor their commitment to beneficence.
And on the flip side, where's shared decision-making mandatory?
In those highly value-laden decisions, think about induced abortion or feticide after a diagnosis of a serious fetal anomaly. There are several medically reasonable paths: continue the pregnancy, terminate palliative care, and the right choice depends almost entirely on the woman's values.
So the physician's job is to be non-directive, to not bias that choice.
They must be.
Finally, let's touch on the end of life and setting limits on life-sustaining treatment, or LST, especially for newborns.
LST is always limited by two things: beneficence, is it providing a net benefit, and autonomy, has the patient or surrogate refused it. When we talk about beneficence limits, we use futility criteria.
Futility. How's that defined?
It's a very high bar. A 97 to 100% prediction of failure to achieve a specific goal. And we have to be precise about what kind of futility we mean. There are three types.
Okay, what are they?
First is physiologic futility. The treatment simply won't work. It can't prevent imminent death. Second is imminent demise futility. The intervention might buy a few days or weeks, but the patient will still die in the ICU without ever regaining the ability to interact.
And the third type?
That's interactive capacity futility. The treatment keeps the body alive, but with an irreversible loss of the ability to interact with the world, to perceive, remember, communicate.
So if any of those are met, continuing treatment is actually causing harm.
It's a net clinical harm, yes, a violation of beneficence. And having these rigorous definitions is why we have to reject vaguer protocols like the old Groningen protocol that just lacked this kind of necessary clarity.
This has been an incredibly dense but really essential deep dive. So if we pull all the way back, what's the big takeaway? What does all this mean for the person actually practicing medicine?
At its core, professional ethics is the tool you use to sustain your commitments to competence, to putting the patient first. It's really the antidote to the distrust that was so common in medicine before these ideas took hold.
And it protects the clinician, too.
It does. It gives you the intellectual discipline to handle the immense cognitive and emotional stress of this work without suffering moral injury.
Here's where it gets really interesting, though, because even with this amazing framework, you're practicing in a world filled with a very specific kind of ethical danger.
We call it the perils of the imperfect expectation of the perfect baby. It's this cultural expectation that's fed by a few powerful things.
They're like,
You've got amazing fetal imaging technology, you have the patient consumer rights movement, and you have this widespread public belief that medicine can and should completely control human reproduction.
so the physician is expected to be a guarantor of a perfect outcome.
Exactly, which is an ethical impossibility. Your professional duty is to actively diffuse that expectation in the informed consent process. You have to say out loud that neither you nor the patient can guarantee a perfect baby. Medicine is powerful, but it's still limited by biology.
Wow, that is a powerful final thought. The job includes managing reality against hope. To help you, the listener, lock in these ideas, let's end with a quick review exercise.
Okay, here's the scenario. A patient has full, intact decision-making capacity. She refuses an emergency C-section, which is the only medically reasonable way to prevent severe fetal distress and certain permanent injury.
The question is this. Based on everything we've discussed, professional integrity, the 3 perinatal obligations, directive counseling should the obstetrician A, respect your refusal and continue with expected management, or B, try to override her decision to save the fetus?
And the answer, the professional choice, is A, respect the refusal. Now, to justify that, you have to go back to that balancing act. The obstetrician has a prima facie duty of fetal beneficence, yes, but they have equally strong duties to the pregnant patient's autonomy and maternal beneficence.
And because her capacity is intact, her autonomy has to be honored.
It must be, even if it leads to a tragic outcome for the fetus. The fetus's status is dependent, and she isn't obligated to take on risks she deems unreasonable. To force the procedure would destroy autonomy, shatter trust, and ultimately compromise the physician's own professional integrity. The process has to win, even when the outcome is heartbreaking.